That's the interstitial fluid. If I get a blister, then that's filled with interstitial fluid. Now this fills also the periodontal space. Periodontal ligament space. Now when a ligament is put under a permanent pressure or stretch, it elongates, whether it's here or whether it's in here. Ligament as a tissue cannot withstand permanent deformation. So we have to remember that about ligament as a tissue, because that's what we're treating every day. So biologically, from the very beginning, we want to understand ligament, interstitial fluid, and the design for natural function of these particular tissues. Now this is one of the biggest lessons I can give you. Now the next tissue is a tendon. How does it differ from ligament? Number one, it's several times more dense. It's a lot stronger, and it does not deform. It doesn't stretch. There's no give in it. So it goes from the muscle to the bone. If it is torn, usually the athlete is just about finished, because the scar tissue that it heals with is much weaker than the tendon. If an athlete tears the Achilles tendon, he's finished. If a horse does it, he's finished. In humans, they let him live, but if it's a horse, they shoot him. And sometimes when the accident occurs, instead of the tendon breaking, the bone it'll pull itself out of the bone. This is called an avulsion. The whole attachment comes out. We had a very famous basketball player by the name of Elgin Baylor that played with the Lakers. He had an accident and pulled his kneecap in two. They went in and screwed the kneecap back together. It healed. He came back and was good as ever. So it is a guy wire. It is like a wire holding. Now we come up with cartilage. Cartilage is a shock absorber. Therefore, it is found in the joints. It's found in places that have pressure. It grows by interstitial growth or by lacunar expansion. Therefore, cartilage surrounds joints at the functional part of the joint. It is smooth and it's oiled with synovial fluid. It has a cooling system. The circulation of the synovial fluids cools the surface. This is something that a lot of people forget. Joints get hot when they're used. And without the proper synovial fluid, there's going to be damage to the joint. Well, cartilage can take pressure and grow under pressure. It can also be torn or broken. And we witness today in the temporomandibular joint what is called an aseptic necrosis, because it more frequently happens in females. It's also been linked to estrogen. All women tend to have more joint disease than does men, in a ratio of 4:1 to 5:1. Women also tend to have more senile osteoporosis. So these are connected with aging, with hormonal problems. This, in my view, makes the condyle a vulnerable site. While we may not be able to stimulate it beyond what its potential might be, there's a little question in my mind of what it can be inhibited with continuous pressure. So we'll be getting into some of this when we come to more clinical science. We're talking about biology right now. There are four main stresses that bone has to resist. If I bend the bone on one side, there's tension on the outside and compression on the inside. I can also twist. That's called torsion. Final one is that I can push directly like this, and that's called shear. So all bones have those kind of situations. It's going to take pressure or it's going to take tension. When we say it's going to take pressure, we say it's going to be a strut. The condyloid process is a strut. It's taking pressure from the condyle. Let's look at this then. As we begin to study bones, and this afternoon we will take up the individual bones. Bone has been described as a calcified system of stress. In effect, you have a matrix. And as that stresses occur on that matrix, in order to resist them, bone is formed. So by studying the system of stress lines, you can study the structure of bone. And it's calcified in response. So one of the problems with these old women is that they just sit in their rockers. They need to get off of their duffs and get out and do something. Just get up out of bed and do something. Wolff's law has been described as the law of functional adaptation. At one time it was interpreted to mean that the form of the bone could be stimulated and made larger simply by exercise or by use. But there is a limit to which that law will apply because it also is a biologic law. But there's little question about the enhancement of the internal architecture of a bone. But there's some doubt that the external form can be altered that much. As we begin to study the bones, we want to look at the functions that they're performing as a key to understanding that shape. We look at the architecture, we find that the stresses run parallel to the trabecula and perpendicular to the sutures. And the forces are running perpendicular to the main line of those sutures. Probably the alveolar process is the best application of the law of functional adaptation. Bone comes into existence with the formation of the tooth and the eruption of the tooth. If there's no tooth there, there's no formation there. What are the limits of alveolar process? Where does it start? And where does basal bone begin? In other words, what part of the maxilla is alveolar process? What part of the mandible is alveolar process? My definition of alveolar process is any part of the bone that was ever connected with the formation or the eruption of the tooth. Because where does a lower incisor start? In a newborn, almost at the lower border of the mandible. When you study a case that has lost the teeth for a long period of time, you end up with only a thin bone down here. All the rest of it's gone. What you end up is a ridge that's back here, but all it's doing is holding up the genial tubercles. An 81-year-old male. Can you see it? Can you see it on television up there? Right here.
Just take a look and see if it moves.
Yeah. Beautiful. Look here. Look how little there is left in the maxilla. This is a false eye. The guy's got a glass eye. And look here how little is left of this mandible. At 81 years, he still had a pretty good looking joint. Compare that to this male here with all 32 teeth. Look at the amount of bone that's present here. Now in turn, muscle is dominated by the nerve. Therefore, nerve dominates bone. So this is the thing you have to remember. Giving this course 100 times, I've tried to alter it several times. One time I tried to teach the technique first. It never was successful. Then I tried to teach cephalometrics and then go back to anatomy. It didn't work. It just didn't work. The main reason that I'm going to go through the sequence in teaching that I do is because by learning this anatomy, when we start looking at the x-ray, you will be able to think in 3 dimensions. So, when you get a lateral head film, you have to imagine all the different depths because all the parts are superimposed. Now once you go through this anatomy point by point, and you have this capacity then to turn this around and look at it in 3 dimensions. And think about its function. You take more to that x-ray than you had before. One of your colleagues here I forget who it was. Sorry. But he did a beautiful job here. Have you seen this? What's his name? Neshita? He was here. And he did a marvelous job of representing this. And one of your colleagues from Japan did this. So he donated this book to the seminar here. A part of the discipline that people come to this course for is to build a self-confidence in their knowledge. We are all teachers and we're all educators. Okay, so here's an opportunity now for you to become the teacher. And what we're going to do now is to discuss why this bone is as it is. Now, the typical cervical vertebrae are very much alike from C3 to C7. When you get down to the thoracic, it's T1, 2, 3. And in the lumbar, it's L1, 2, 3, the way that they talk about it. So we talk about C1, C2, C3, C4 as the number of the vertebrae. The function of the vertebra is to hold the head up and at the same time prevent movement, support and permit the motion to take place. The head sits mostly on the bodies of the vertebra here. If you all got one in front of you, take a look at it. So looking from the front, it's this part here that is carrying the head. You notice there's a little lip there on the top to keep the top member in check. See? Now, right behind this, then, are 2 little connections that go over to the transverse processes, which is perforated for an artery that runs up along the side of the neck, protected by the vertebrae, in which it then comes in the foramen magnum up into the brain. Now, in back of this lateral process right here, at this location, are 2 lateral processes. These, if you notice, are immediately lateral to the spinal column. So I'm going to give you a principle in architecture. The blood supply and the nerve supply run close to the center of rotation. Blood and nerve supply don't want to be stretched or sheared. So we have a blood supply running right up laterally, right in the center of motion. The blood supply comes in under my arm, on the inside of my elbow, on the inside of my wrist, on the inside of my knee joint, on the inside of my hip joint. Hold up your occipital bone. Where does the blood and nerve supply come into the head or leave the head? Right at the occipital condyles. See it? Where does the blood and nerve supply come into the mandible? The mandibular foramen. Teleologically, I use the word teleologic. Have you got that?
No.
I use it to explain that you can just tell telescoping logic is really projecting logic. You will hear me use the word teleologic reasoning. Now, if that principle holds throughout our bodies, and we see it not only in humans but in all animals, what may you then deduce or abstract or reduce from the mandibular foramen? That would be the center of the motion of the mandible. And there it is. Xi point is the center of rotation of the mandible. What else? The occlusal plane comes right there. So it's side to side and open and closed. The center of rotation is not up in here. The center of rotation is at Xi point. Because that's where the mandibular foramen is located. That's where the blood and nerve supply comes in. So when you take the whole thing into consideration, that's the center of the motion of the mandible. So we see the same principle right here. Now, we have support then. The main support is coming from the body with the intervertebral discs. Now, lateral to that then, you have two other supports. But if you notice, they're at a 45-degree angle. You notice this? This is oblique. This is 45 degrees from that. And what does that do? That forms a lock. So that prevents displacement from taking place. Now, coming off from the back, you have a handle. But what's attached to it? Muscles and the ligamentum nuchae. And in males, you have a very big prominence in the back of the head here. In males. It's called an external occipital protuberance. It's called external occipital protuberance. And to it is attached the ligament, ligamentum nuchae. And this ligament attaches to the spinous processes of the vertebra all the way down. So, what did we say the ligament was there? As a stabilizer, as a checker or a restrainer against displacement. Why are we interested in the neck? As orthodontists, as orthopedists, what is one of the most common symptoms that we see in temporomandibular joint disease? TMJ, headache, neck pain. It's all a part of an organ. And so we have to become involved today. Anybody who puts themselves out as a specialist had better know something about the neck. The situation then is one in which you have a tripod. You have 3 points of support, one in front and one on either side. The fourth side, instead of being support, is for displacement and stabilization in the other direction. So we have a tripod. And keep in mind then that we start 7, 6, 5, 4, 3. Now I'll make a statement. Centric position of the teeth is determined by the postural apparatus of the neck. Centric occlusion of the teeth is a product of the cervical apparatus or the postural apparatus of the head. Every dentist recognizes a centric. Right, now what causes it to develop? If it's centric, how does it develop? And if you have a premature contact, how does it develop? So the occlusion then is developed in response to all of the aggregate of what's going on in this whole complex. One of the things that you see in prosthetic dentistry are patients that have been edentulous for a number of years. And one of the things happens is that the patient comes in and they look like this. In fact, we discovered this when we started taking x-rays in one of our studies of older people. We couldn't get the chin on the x-ray plate. So I had a technician doing these at the General Hospital where we were doing this study on older people. And I said, drop the x-ray plate more so that you can get the hyoid bone and the chin and down to at least the 5th cervical vertebra. On the x-ray plate. Very early in my career, I had a lot of patients with whiplash with TMJ disease. And we don't see them that often anymore because of the headrests and the automobiles. So I've been interested in the neck ever since. Now the reason I'm telling you this is because this is a part of my therapy.
今示したこの頸椎ですね。こ
Part
れ
of
が
my concern
重要で
today,
あって、
1991 orthodontics.
もう現時点の1991年のその治療というのはここから始まらないといけません。
The mandible is in this whole sling of muscles, and so I'm not talking about just this because it is of academic interest. It is of clinical interest.
つまりですがこの頸
And
椎
what I lose here in height has to be compensated for back here, or else my eye level won't be correct.
調査をし
When
な
a
ければ何に
patient
もならない。
develops a closed bite,
クロー
his
ズバイト
mandible just doesn't go up in space up in here.
クロー
And
ズ
what
バイトが
happened
前に
is
出ている
all
わ
of
けで
this
す。
would be opened up too much.
つまりここのところの筋肉がすっかりそのラフになって
So what happens is the mandible starts to close up, but
そうし
then
て
he
だんだん
brings
価
the
格がそ
maxilla
の上がっ
down.
ていって、
And then his side is thrown off, so he does this to level off his side again.
出てくると。
We're going to raise that bite. Going to increase the vertical here.
ですがこれだけ最終的なバーティカルと高くしてやるためにバイトを上げなければならない。
His head would be thrown back. So now he has to do
だから
this
こういうふう
in
に後
order
ろ
to
に
get
や
adjusted
ら
again.
ないと。
You follow? So the vertebrae are of concern to us.
ですから
And the truth is, it's just about the first place I look at an x-ray.
でその
Okay, now let's have the axis. It has the task of terminating the anterior body support. See, we have a central column that's coming up here,
まずこれ
but the head
ところが頭という
tips
の
this
は
way.
こういうふうに前後にこうなりますから
We have to have some. This is a stop.
なんかストップ
What we have here in the body, as he's drawn,
今
is this central part
まず中心部があって
spreads,
そして2つに分かれているんです
and it forms a Y.
で Y 字型になります
So this force here
でここにかかった力は
goes laterally
外方に向かって2つに
and
分かれます
separates. So looking from below, we have
下から見上げた
the
時
same 3 points of support.
そうします
But looking on the top, you only
上から
have
見ま
2.
す上から見ると2箇所だけで支えられている形です
So 3 points of support
まず仮面からは3箇所で支えられていて
are translated then to 2
で
points
それが
of
上に
support.
上がってくると2箇所で支えられることになります
Meanwhile, there is another lever
それでその間もう一つこうレバーになっているところがあって
that comes from the top
で
now,
これは上から来るものです
and that is the epistrophius. And the head really turns around this spindle.
停止します
This is locked into
ただ
the
ここの
atlas
部分は
by a ligament that runs right behind it,
後ろ側
the transverse ligament in the
応
atlas.
送
So this really becomes a spindle on which the head turns.
ですからこれをいうふうに回転する機構になっていて頭もこれ
The
の
very
ことにな
top
り
of
ます
this has a ligament that goes over.
てっぺんにも靭帯
To
の
the
血がカバー
occipital
してい
bone. This part is called the dens.
て
The whole thing is the epistrophius.
死と
Now, if you look in the back then, this is a large spine.
どう
In fact, this is big enough to the size of the end of my finger. And here muscles run laterally to help stabilize this from side to side. And here's the end then of the transverse processes and the transverse foramina. I like to think of this bone as having a couple handlebars. Like the scooter, you know, you have a scooter, 2 handlebars. Okay, this has a posterior arch and an anterior arch. It's a keystone. You know when you make an arch, the keystone. You know what the keystone is in an arch? In Europe, and look at some of the old bridges. Here's the ground, and here's the water, and they want to make a bridge over it. Okay, they're going to make an arch here. And the very last one has this shape. That's called the keystone. That's the keystone. That's the last stone to go in, and then the weight is distributed outward on this. So this is the keystone. See here? That locks in the neck with the head. See it? Can you see that? Kiko? So here are these 2 handles then that control this with muscles going up to the head and down to the neck. And very interestingly, the only thing it permits is the head to move this way. When the head moves side to side, the action takes place with this bone against the lower bone. See if we can get that on TV. Get me up close. Can you zoom up? All right, zoom up here. There we go. All right, now, when the head moves from side to side, rotates, it moves like this. See, it moves around the dens, or around the epistropius. So what does that remind you of then? A universal joint. You know the universal joint and the drive shaft of an automobile? The car has to bend when it goes over a rock. And so that universal joint has to work. So this is the universal joint for the head. Here. Here's the anterior arch of the atlas. Here's Basion right here. So if you notice, the anterior arch is right in front of Basion. This is a cut through the middle of the head.